It's my honor to present at our Grand Rounds, and this date and time, it's Amy helped me to set it up back in May or early June. The topic I am going to share with everyone is the significance of glomerular galactose deficient IgA1 on kidney biopsies in patients with lupus. Okay, I have nothing to disclose. And I basically will go through the presentation, first describing a diagnostic challenge case on a kidney biopsy. And then I'll briefly go through the pathogenesis and pathologic findings of IgA nephropathy, and then share our data on the IF staining of KM55 in the diagnosis of kidney biopsy from patients with lupus, and then a brief summary and our future studies. Okay. So the first, because I'm basically a clinical diagnostic pathologist, so all the questions I had in my mind, or all the research or translational research I'm doing, is inspired by the biopsies that I read every day. So this is a case, actually I can share with any of the cases, but this case we submitted as a case report. So I think it's more easier to share like this way. So this is a biopsy from an 11-year-old girl. She had a recent diagnosis of lupus 3 months ago before the kidney biopsy is performed. And she had been treated with steroids and hydroxychloroquine. And then because she is being followed up closely, and then on one of the labs, it shows new onset of proteinuria. It's a small amount, it's less than 1 gram. And then UA showed microscopic hematuria, only 3 red blood cells detected by the UA. Serum creatinine level is normal, complement levels are normal, and serologies actually is returned back to normal, comparing with the serology at the time of diagnosis of lupus. So the concern is, does the patient have lupus nephritis, right? Because the patient has a clinical diagnosis of lupus. Although with the treatment, clinical and serologically, she is doing better, but the urine shows proteinuria and microscopic hematuria. So with this clinical picture, the most common finding is likely to be either class 1 or class 2 lupus nephritis. So this is the light microscopy finding of this patient's biopsy. Only rare glomeruli show this mesangial expansion and mild mesangial hypercellularity. So the gloms looks quite pristine, very good morphology. And then here on the silver stain, we see same finding, essentially mesangial expansion, mild mesangial hypercellularity in a few segments. That's by light microscopy. That means at most is class 2 lupus nephritis, which dictates with mesangial hypercellularity. On the IF staining, it shows positive staining for IgG, IgA, IgM, although dimmer for C1q and C3, but they are both at trace level, and then both light chains, kappa and lambda. So by strict definition, this is a full house staining pattern, which means 3 heavy chain and then the complements staining, both the classic pathway and then the alternative pathway. So that's by strict definition. Then the EM confirmed the findings by light microscopy and IF, which shows electron dense deposits in the mesangial region, here and here. And then the foot prosthesis is roughly mostly preserved endothelial cells, show preserved fenestration. So it's a simple case. However, the diagnosis is not that straightforward, because depends on how we interpret the findings. We could look at this as, okay, it's a full house. It's not typical. It's not very classical full house pattern because we did not see bright C1q or C3. But we can interpret it as IgG codominant, which means I have bright IgG and IgA. However, if we go with, depends on how we view it, we can view it as IgA dominant with some IgG, and then minimal C1q, C3, and then minimal IgM. Then I would go with this is IgA nephropathy. So the differential diagnosis is lupus nephritis versus IgA nephropathy. The treatment and management is different. So is there something that can help us to really nail down the diagnosis? So let's pause here. There is a recent paper, not that recent, published in 2019. The group from Columbia, they studied the sensitivity and the specificity of the IF findings for lupus nephritis. The reason this study was performed is because the pathologist, we were granted the power to diagnose lupus nephritis, even in patients with the first-time diagnosis, which means if the pathologists are aware of positive ANA or positive ANA with double-stranded DNA antibody, and then the morphological findings consistent or compatible with lupus nephritis, the pathologist can call lupus nephritis straight out. So that means with the granted power, actually we need to be cautious. We do not want to overcall lupus nephritis because the full house staining is not specific for lupus nephritis. That's why this study was performed. Although lupus nephritis has a long history being recognized, and IgA nephropathy was recognized in 1960s. Okay, so what they found was there are 5 features that carries some weight in terms of sensitivity and specificity for lupus nephritis, which include full house staining, which means what we just mentioned, and then strong C1q, tissue ANA detected by IF, and then extraglomerular deposits either detected by IF or EM, and then endothelial tubular reticular inclusions detected by EM. Okay, so these 5 features. And then with these 5 features, if we see as many of these features, the sensitivity decrease, but the specificity for lupus nephritis diagnosis is increased. Okay, so then we look at our case, we will come back later. So IgA nephropathy is not a benign disease. That's started with my first day of fellowship training. Dr. Haswood told me that. So as we know, depends on the center where the IgA nephropathy was studied, the kidney survival time actually at 10 years varies a lot, but about at least 10 to up to 50% of the patients might lose their kidney or progress to end-stage kidney. Okay. So then what's the definition? What's the diagnostic criteria for IgA nephropathy? It's defined by the IgA deposition as the dominant or codominant in the mesenterium of the glomes, detected nowadays, most commonly detected by immunofluorescence staining, which is shown here, or by immunohistochemistry staining. That's also acceptable. And no requirement in terms of what other immunoglobulin heavy chain staining. Okay, so that's a simple, straightforward diagnosis. But if we go back to 1989, 88. So as I said, IgA nephropathy was recognized in 1962. But as we see, even like after 20 years, we have this milestone paper published by Charles Jeanette. So they studied the features of IgA nephropathy. As we can see, at that time, the requirement is the patient has no evidence of lupus. That's one requirement. And then the criteria he proposed was IgA staining got to be 2+ if it's IF, or even greater. So minimal intensity got to be 2+. And then IgA can be dominant or co-dominant. But the other feature requirement is C1q got to be less than 2+. So when we look at the picture, so to the right side, this is lupus nephritis. So as we can appreciate, it is a full house pattern. And also we have bright IgG and bright C1q. So that's the classical lupus nephritis IF pattern with full house and then kappa lambda equivalent staining. Okay. On the other hand, this is IgA nephropathy. We can appreciate IgA is brightest. And then as in this paper, the requirement is slow C1q staining. And then, but we can see some IgG, IgM. Again, we can see some full house pattern. The interesting feature for IgA nephropathy is kappa lambda. We see a lambda predominance. Okay, so that's the classical patterns of IgA nephropathy versus lupus nephritis at the time of 1980s in that period of time. The reason is because lupus nephritis, okay, let's keep going, fast forward to the definition of IgA nephropathy. So this is from the Oxford classification of IgA nephropathy, originally published in 2009. And then in 2016, there is an update Oxford classification. In this classification, we only included MEST, but then in 2016, we included another feature, MEST plus C, which is crescent. Okay, so coming back to the definition, even for this Bible of IgA nephropathy study, the requirement definition changed, but still we see it's co-dominant or dominant IgA, and then we need to exclude lupus nephritis. And then the requirement for IgA intensity is dropped to more than trace. This is a more reasonable because before that, 2+, 1+ is not uncommon. Okay, and then the last sentence, as we again seeing that the presence of C1q staining in more than trace intensity should bring up these consideration of lupus. So we could understand, for the study of a IgA nephropathy, we want to be really pure selection of the cases of truly IgA nephropathy. But even knowing this, the entire, get a few key time points to look at how IgA nephropathy was defined. This is very helpful, okay? And then the pathogenesis of IgA nephropathy, although we know this entity back in 1960, but still, even at this moment, I'm just sharing what the most updated pathogenesis is. So we believe, so normally this is in human, we have two types of IgA, IgA1 and IgA2. So IgA1 is seen in human and other animals. Their IgA, they only have one form of IgA, and then their form, it's similar to, there's a question. In the animals or even primates, their IgA is similar to human IgA1. And then for, similar to IgA2. And the human has this unique IgA1. In this IgA1, we have 6 points where we normally we will have galactose, glycosylation. Okay, so the IgA1 included is usually the IgA1 in human circulation or in the tissue. It's glycosylated IgA1. for patients with IgA nephropathy, their IgA1 is galactose deficient IgA1. So our current understanding is the galactose deficient IgA1 is playing an important role in the pathogenesis of IgA nephropathy. Okay, so the multi-hit hypothesis of IgA1 that is the most widely accepted pathogenesis nowadays. So the findings are the serum galactose deficient IgA1 is elevated in patients with IgA nephropathy in comparison to controls. And then the multi-hit hypothesis is for any reason. This can be caused by infection, by viral infection, bacterial infection, genetic background, even food, cause the increased level of galactose deficient IgA1 in circulation. And then this initiated the generation of autoantibody. And either the antigen and antibody, they form the immune complex, and then these immune complex, they are in the circulation and then deposited in the kidney. So that's the most widely accepted pathogenesis. So, but this part, the immune complex may be formed in situ in kidney or formed in the circulation and deposited there, okay? We can fast forward this part. But the key feature here I wanted to point out is CD71. That is a receptor of IgA1. So galactose deficient IgA1 will increase the expression of CD71, which usually is low, the expression level is very low. The presence of galactose deficient IgA1 will increase the expression of CD71 and then help to bind to the galactose deficient IgA1, forming this positive enhancement. Okay. And then we keep, as we have more understanding of this galactose deficient IgA1 in the pathogenesis of IgA nephropathy, in the group in Japan, they published a paper in KI in 2018. They had developed the antibody to the specific to galactose deficient IgA1. So as we see in their paper, they claimed that IgA nephropathy and then their twin brothers or their twins, IgA vasculitis, which is HSP. The old terminology is HSP. So it's specific for this galactose deficient IgA1. It's specific for primary IgA nephropathy and HSP. So what they show, I highlighted some of them. So in IgA nephropathy, which with routine IgA staining, they're positive as the definition. And then KM55 is also positive in a similar pattern and a similar intensity. And similarly for IgA vasculitis nephritis, which is HSP nephritis. Again, we see IgA positivity, and then KM55 is also positive. In all the cases, they tested for IgA nephropathy and HSP nephritis. But for none of other entities, they tested with this antibody, which is KM55. They are negative. So that's how they feel the KM55 is specific for primary IgA nephropathy and IgA vasculitis. However, after this paper, as any marker that at the beginning was claimed to be either sensitive or specific. So more studies were published in the later years, 2019, 20, and then 2021. So basically, their study confirmed that, yes, KM55 staining is positive in IgA nephropathy. However, it's not specific for primary. They detect the positive staining in secondary. So basically, that's what they're claiming. And then I put in a quick summary of this KM55 antibody staining, immunofluorescence staining, so that we can see that. So this is the original paper from the KI 2018. They tested 62 primary IgA and HSP nephritis cases. These are all kidney biopsies. 100% are positive. And then for the secondary forms of IgA nephropathy and the infection-associated GN or other, even the incidental IgA nephropathy, their findings are all negative. And then for the subsequent studies, again, 100% of the cases tested for stained for KM55 positive for IgA nephropathy, 100%. For secondary, they have variable staining results. The two of these studies, they show 100% staining, which means it's not specific, but the sensitivity actually is still there, right? For the post-infectious GN, this study published in NDT by Columbia group, by Ohio group, they have variable staining pattern, variable positive cases. Okay, other cases, they have similar results as the first study, but not here. Okay, so actually, these are not what I'm exactly interested in. And then let's look at the next table. So this one, I summarized the IgA nephropathy and lupus nephritis, because this is exactly what we are hoping KM55 staining, if there is any value. I think this would be where it's helpful. Okay, so again, this is the same findings, but for lupus patients, our original study is 0% positive for KM55. The second study, also 0%. And then for the last two studies, 100%. But as we can tell, the last two studies, they are done from Asian countries, China and Japan. And then this group is in Ohio, and then they got 3 out of 8 of the cases that are positive. And then the intensity-wise for the KM55 ranges from 0 to 1+. The brightest is 1+. Okay. However, in this study performed in China, the intensity ranges from 0.5, which is trace, to 4+. So that means there are truly some positive staining. Okay. So actually, this finding is very exciting. So then our questions, or what we are trying to study, is can KM55 staining distinguish IgA nephropathy from lupus nephritis? So that's the first question we ask. If it can, then the next step is for patients with lupus, can we identify IgA nephropathy in patients with lupus? Okay. So to answer the first question, we selected patients with, IgA nephropathy, purely IgA nephropathy. These patients got to be non-lupus patients. And then we have 25 cases. We have a lot more than that, but we selected 25. And then for classic lupus nephritis, we selected 20 patients. The definition for IgA nephropathy, to answer this question, we have to use very clean data. So IgA inclusion criteria, we use the same as Oxford, which means IgA staining in mesangium by IF greater than trace. And then we want to have minimum C1q, less than trace. And then patients clinically do not have lupus. For classic lupus group, the patient got to have clinical lupus nephritis, classic SLE presentation with extra-renal involvement. And then for the kidney, we want to see IgG dominant full house staining with bright C1q, and then IgG greater than IgA with more than 1 grade, which means, for example, if IgG is 3+, IgA is at most 2+. So with these 45 cases, what we find is, okay, so I don't know if this one is blocking. Okay, so the first two images are from IgG, and then this is IgA, the middle column IgA, the right column is KM55, which is galactose deficient IgA1. Okay, so for IgA nephropathy, IgA, essentially we have minimal IgG. So I selected a case with a little bit of IgG staining. Actually, majority of the IgA nephropathy cases has minimal IgG, okay? But bright IgA, and then these cases, they stain positive for KM55, which is the results are consistent with all the published data. For lupus, classic lupus nephritis in lupus patients, so these patients, they have brighter IgG than IgA. They have the full house staining. And interesting, in these cases, they essentially have zero staining. A couple of cases has zero to trace staining. This is one of them. Most of the cases, they have dead negative KM55 staining. Okay. So if we look at the intensity, so this is a KM55 score. Lupus nephritis patients, they at most is zero to trace KM55 staining. Majority is negative. For IgA nephropathy, we have the range from trace to 1 all the way to 4+. And then that's the KM55 staining. And then with really the average intensity is 2.5. Okay. And then when we study the correlation of KM55 with IgA nephropathy, we have really nice correlation with IgA nephropathy, but no correlation with lupus nephritis as we predicted. And then it can distinguish very well between IgA nephropathy and lupus nephritis, classic, okay? So with this in mind, then we feel like we can move one step further. What if this IgA nephropathy is happening in lupus patients? Okay, so that's our first part of the study. So then to answer this question, we did it stepwise. The first step is, do we have IgA nephropathy cases in lupus patients, right? So the answer is yes. So in the literature, we have this total 9 reports. They are mostly case reports or case series. At most, each study has like 3 patients. First of all, for patients with lupus, they're in patients when they have end-stage renal disease, about 0.3% of these patients, actually, they are caused by non-lupus nephritis. We do acknowledge that majority of the kidney in lupus patients with ESRD is caused by lupus nephritis. However, with a very small or uncommon situation is caused by non-lupus nephritis. And then IgA nephropathy is the most common GN, and then it's reported in 15 patients, as I just talked about. And then interestingly, if we look at this report, one patient had 2 sequential biopsies. The first biopsy, it was called lupus class 2, which means it has mesangial hypercellularity. And then the second biopsy, it was read as IgA nephropathy. Actually, this situation in our real life is not uncommon. We do have seen this. And more interestingly, for a patient with lupus that cause ESRD after transplant, when the lupus nephritis recur, actually the first time we see, it's questionable, is this lupus or is this IgA nephropathy? So that's kind of like the situation. So anyhow, these published case reports support the thoughts that, or they provide the evidence that IgA nephropathy can be seen in patients with lupus as a sole lesion, right? So we collected a total of 11 biopsies, which are called IgA nephropathy, and these patients had lupus symptoms. Okay. These cases, actually, I got them from 4 different centers altogether. It's not common. And as what I only wanted to point out is these patients, 4 of them are Asian, and 6 of them are Hispanic, 1 of them is white. So as we know, IgA nephropathy has a higher incidence in Asian and then Hispanic population. Okay. And then for these patients, here are the key information. For IgA is 2 grade, 2.5 grade, so 2 to 3 plus. And then for IgG is 0 to trace, it's minimal. And then we do have mesangial C1q as they are all negative. And then as we can also notice, kappa is 1.2 and then lambda is 2.4. So it has a similar pattern as we've seen in classic IgA nephropathy. So we are confident. All these cases were reviewed centrally. I reviewed all the cases. And then what's interesting of these is we had one biopsy, one patient who had positive tissue ANA. As we previously reviewed, tissue ANA is seen in patients with lupus, but that does not mean the patient has to have lupus nephritis. And then also for tubular reticular inclusions, which can be seen in lupus nephritis, in HIV, and even in CMV infection, we can see TRIs. And then 2 of our cases showed positive TRI detected by electron microscopy. And the KM55 staining, the average intensity is 2.18, which is a little bit dimmer than the routine IgA, but keep in mind the original IgA was stained on frozen tissue, and then KM55 staining was done on paraffin tissue, which naturally is a little bit dimmer and with higher background. Okay, so we feel this really, the IgA nephropathy in lupus patients, actually they behave the same as IgA nephropathy in non-lupus patients. So the case I selected to show here is, this is a lupus patient, as we can see by these arrows. These are highlighting the tissue ANA, which is stained the nuclei of the epithelial cells. Here are podocytes. And then the mesangial, but in the mesangium, the IgG is negative. And then here, this is a bright IgA, and then similar pattern of KM55 staining. Again, IgA nephropathy in lupus patients are identical to IgA nephropathy in non-lupus patients. Then the next question is, do we have concurrent IgA nephropathy and lupus nephritis happening in lupus patients? I know a lot of lupus. Okay, so if in the literature, we had publications showing evidence of overlapping IgA nephropathy and membranous nephropathy, because they have different staining pattern. Membranous is on the capillary wall. IgA is in the mesangium. So these provide unique opportunity to recognize 2 different nephropathy happening in the same patient. It's not rare here, and we also have other publications here. Primary GN with detectable glomerular Hep B. So for Hep B patients, they tend to have membranous nephropathy, and then also IgA nephropathy was detected in this patient, in these patients. Okay, so to answer that question, actually, there are 2 cases of all the centers that I collected together. I saw this type of case when I was in training. So what's interesting is here, this is a lupus patient, a kidney biopsy. We see IgG bright staining. They are along the capillary wall. So we see they're in the walls, but also there is mesangial staining. Okay, but for the IgA, the predominant deposits are in the mesangium, the chunky part, but in the capillary wall, essentially it's negative. Okay, and then for these patients, because of the deposits at different location, different locations, so we can recognize they have different patterns. And then the KM55 staining is positive, and in a similar pattern to IgA. So this provides, as I said, unique opportunity to recognize two different entities happening in these two lupus patients with concurrent IgA nephropathy involving the mesangium, and then lupus membranous, not class 3 or class 4, involving the capillary wall. So, and the KM55 is consistently detect the IgA component. Okay. So with these two steps, I think it builds a good foundation to investigate the next question. Does lupus nephritis cases that we have been only calling them as lupus nephritis, actually including some of the cases with both IgA nephropathy and lupus nephritis, is possible? So then the third step, I only studied the cases that we called it lupus nephritis, but they have either dominant or co-dominant IgA and IgG. So for these, we look at the definition we changed for the lupus. Not the definition. We selected the cases with, again, strong IgG and strong C1q, which is fulfilling the diagnostic criteria for lupus nephritis. However, it has some features that I wanted to select the cases with the difference between IgN and IgG is less than 1 grade. For example, if the IgG is 3+, the IgA can be the same 3+, or IgA as 2 to 3+. The difference is less than 1 grade difference. And then even the IgA can be brighter than IgG, because I feel like, okay, these cases, we still called it lupus based on these features, and then we kind of ignored how bright the IgA is. So for these cases, interestingly, we detected three different groups based on how the brightness of IgG and IgA. So these first two rows, I would call them co-dominant, IgG and IgA, because both IgG and IgA are very bright. Because they're so bright, it's harder to tell which one is more dominant. And then the bottom row are the cases that IgA actually is brighter than the IgG. So interestingly, when we look at these top two groups, some cases they stain positive for KM55, which means there are galactose deficient IgA1 deposited in the kidney mesangium. And even here, even the pseudo thrombi in the capillary loop, they stain positive for KM55. That means there are in their circulation. And in some cases, they are negative. So as we can see, for the co-dominant IgA, total we had 14 cases, and then 8 of them is falling into the first row, are positive for KM55. The remaining 6 cases, they are negative for KM55. Okay, so we feel like this is a mixture of, so where we usually call lupus nephritis with co-dominant IgG and IgA, actually it's a mixture of KM55 positive and KM55 negative lupus cases. And then when we do this analysis, we can tell the overlapping feature. The blue dots, they are IgA in lupus patients. And then the gray or black dots, they are lupus nephritis in lupus patients with classic lupus nephritis. And then the pink or the red circle, that represents co-dominant cases. Okay, so that's where we are. That's a quick summary of the findings. So far we feel comfortable that KM55 can distinguish IgA from lupus, whether it's in non-lupus non-lupus compared with lupus patients, or in the IgA nephropathy in lupus patients. Okay. And then for lupus patients, we feel also comfortable. If KM55 is negative, we feel like the patient does not have IgA nephropathy. If the patient only then that means the patient may only have just lupus. However, for greater than trace of KM55 staining, suggests there might be a component of IgA nephropathy, even for patients with lupus. So that's all the pathology findings. And then for the future study, or what we are doing, trying to explore right now, is at the beginning when I introduced the pathogenesis, we talked about CD71 in the mesangium, the expression. So normally, CD71 has really minimally or really low expression, but for patients with IgA nephropathy, and then or HSP, so IgA, Berger disease here is IgA nephropathy, and HSP is the HSP or IgA vasculitis nephropathy. The expression of CD71 is enhanced, is increased, elevated. And then when we look at other studies that look into lupus, because CD71 at one point was trying to be used as a marker for proliferation injury, which means they are more advanced, more severe lupus nephritis. So as I put these together, as we can see, so some of the lupus patients, when they did CD71 expression, they have variable staining, right? And then other lupus cases, they do not have any expression. I feel like we are encountering or we are seeing similar situations as when we started to look at KM55. I think it will be interesting to do CD71 and the KM55 staining, dual staining in lupus cases. I'm curious for the KM55 positive lupus cases, if they are also positive for CD71, or if the CD71 detected in lupus nephritis cases, are they because of the presence of galactose deficient IgA1? I think that's interesting to explore. And then also to look into the lupus nephritis patients, if we do KM55 and then separate them into two groups, KM50 positive and then negative groups, see if the clinical outcomes are the same. Because if our detection is truly reflecting these cases are dual GN, which means IgA nephropathy superimposed, or lupus nephritis superimposed on IgA nephropathy, versus purely just lupus nephritis, their clinical outcomes might be different. So I think that's worth more investigation, collaboration with the nephrologists. And then the last part, thinking to do the spatial digital profiling to see if the cases with IgA nephropathy, and then cases with lupus nephritis, and then the cases that we think there are two diseases, if they have different genomic gene expression. So I think those are questions will be interesting to explore. Okay, and then last but not least, so Dr. Kim, who is a pediatric nephrologist, he has been of tremendous help. And then we have been having a lot of conversations, discussions about the findings and the studies. And then these are the pathologists, the three pathologists from Cedars-Sinai. She contributed a significant number of the cases, especially the rare cases. And then Dr. Lai in Hong Kong, he is also a pathologist, and then very well known in IgA nephropathy. And then Dr. Joe, when I was a resident in Dallas, he was there, and then he moved to Baylor. So all these, I got support from them contributing the cases. They sent the slides here, and then we did the staining at ULFM. And then I had a student, Bayardo, who did the analysis for us. Okay. So, but last but not least, the study was supported by our department. Without the support, we will not be able to do any of these work. Okay, thank you very much. And I'm happy to answer any questions you have.
Can we go on with the questions?
So,
yeah. Okay, so Leon, thank you very much. That was a very good overview of IgA nephropathy and the work that you have done. I have two quick questions. The first one is about the CD71, which the heme path people use for a different reason, and it's a receptor for something else, at the transferrin.
Transferrin receptor. Yeah.
So, do we know that it is specific for galactose deficient IgA, or is it the receptor for IgA, including normal IgA? So that's the first one, which might change the interpretation of especially your future study. And the second question is the KP55 antibody. How does it compare with C1q? Why is C1q not enough to differentiate some of this IgA nephropathy from lupus nephritis, especially those patients with, well, that's a standalone question. And I think maybe an attached question would be, what does the C1q look like in that patient with lupus class 5 and IgA nephropathy?
Great questions, Dr. Day. So first, a question about CD71. So yeah, because I set a timer for myself. I feel each time when I talk long. So I went fast for this pathogenesis part. So for this, number one question, CD71, is it specific to galactose deficient IgA1? Based on the literature, it is specific for galactose deficient IgA1. It's not for just the normal galactosylated IgA1. That's a simple question, a simple brief answer to your question. And then as we can see, the galactose deficient IgA1 here, when the circulation or even in the polymers of galactose deficient IgA1, it can bind to CD89 and then got shredded from the monocytes, off the monocytes. So the other receptor, or there are multiple receptors that galactose deficient IgA1 will bind to. The most predominant or the receptor play important roles are CD71 and then CD89. So these are the two. The second question coming, did I answer a question? So that's a brief answer.
Yeah, So but the question now of C1q, because
yes,
most of the time that you show the KP55,
yeah,
I'm not sure, maybe I missed the comparative data with C1q, and I'm not sure if C1q wouldn't have told you the same thing.
Yeah, I got the question. Yeah, I was going to move on. Okay, so for second question, let me go back to this. This old study actually is a great study. So as we can see, even for the IgA nephropathy, we can see some C1q, right? And then although at that time, the classification or definition, they were trying to come up a criteria to diagnose IgA, because IgA nephropathy is a new kid on the street. Lupus nephritis has been long recognized, many years ago, before this IgA nephropathy, when IgA nephropathy was recognized as a Buerger's disease. So they didn't have that much, space to take up. So then that's why, we need to make sure it's not lupus, number one, and then think about IgA nephropathy. So in classical situation, C1q is bright in lupus. Let me finish for the lupus first. If the patient has been treated, especially when, nowadays, a significant number of nephrologists. So in the past, we feel like, okay, lupus patients, about 1/3 will have lupus nephritis. If they had a biopsy diagnosed as lupus nephritis, usually this patient will not have repeat biopsies unless the patient has a really dramatic change in renal function or proteinuria or something that could not readily be explained by clinical other symptoms, right? So, but nowadays, a significant number of nephrologists, they are proposing to repeat biopsy these patients so that they understand how much chronicity and then whether the activity, how they need to adjust their medication. So that's the second part. But the interesting thing with this repeat biopsy, actually, it helps us as a pathologist to recognize even these patients with classic lupus nephritis on the first biopsy, if they're treated, their C1q levels, actually, they drop. So that's why C1q alone, even in patients with classic clinical lupus, versus non-lupus patients with IgA nephropathy, the role of C1q is too risky to be used as a diagnostic ancillary marker to feel confident to call it. So that's why when this case this case report, when we're talking about this C1q, this dim C1q can be seen in patients treated, especially recently treated. This patient was treated like only 3 months. So that's about C1q. And then the next step is now we are thinking that for the cases that I usually, especially for the co-dominant cases, which I would have no hesitation, these cases, I call it directly as lupus nephritis. I would not even think about IgA nephropathy. Mm-hmm. So for these cases, now we feel like it's a mixture, at least by phenotype. Some of them are positive for KM55, some are not. So they are a mixture of cases. So with this study, at least whenever I read these, I will pause and then check more history and then think about if the patient already had hematuria before the diagnosis of lupus, before clinical presentation of lupus. Well, I may put a comment saying, I recommend doing more study, or I cannot rule out the possibility of 2 GNs. So.
Thank you.
Thank you.
Lihong, this is John Cross. Fantastic study. I really appreciated this. Actually, I have 3 different questions. Number one, in your first case, I noticed that the EM showed distinct paramesangial deposits, which obviously is quite characteristic of IgA. Is that at all helpful in separating the IgA from lupus nephritis? I'll let you answer that one, then I've got 2 others.
Okay, so this is a great question, Dr. Crossan. Actually, when I was reading this, I feel like this got to be IgA, but I cannot say how confident I am, because for lupus nephritis, this is kind of like a more paramesangial. Mm-hmm. This can easily be seen in lupus. And then also depending on the angle of how the EM is sectioned, I feel not that confident. Yes.
And then the second question is in the studies that you showed with secondary nephritis, secondary to let's say cirrhosis or something, some of those patients were actually KM55 positive, if I remember. Is that correct? Yeah, particularly in that I think, I don't remember which slide it was, but I think some of them were.
The picture. This
yeah,
one.
yeah.
Okay.
It is in the secondary IgA deposits in patients, let's say, who have cirrhosis. Are some of them KM55 on occasions?
So that's a great question, Dr. Crossan. So actually, that's when I was reading this paper, I immediately thinking about to buy this antibody and to do the staining, because as you know, by morphology, we cannot distinguish primary IgA nephropathy from any like hepatic, HCV or hepatic IgA nephropathy. These are all secondary IgA nephropathy for people who are not in renal field. And then also this study. So actually, after reading this paper, the first three things I wanted to do is, okay, does it really help to distinguish primary from secondary? Because that means then I don't need to spend so much time looking into the chart. I can tell, okay, primary, secondary, because secondary, they do not need to be treated. They treat the primary disease. Mm-hmm. And then this is also important. That's why I generate this table. Infection-associated GN, the treatment is completely different from the IgA nephropathy. If this is a magical marker, that's fantastic, because we have cases, especially for the diabetic patients with, skin infection. Those kidneys, we can see IgA dominant proliferative GN. It's morphology-wise, it's sometimes so hard to tell them apart. If this can tell, okay, this is negative, then I feel so confident. Okay, infection. Then they just give antibiotics. Yeah. And then the last part is incidental IgA nephropathy, because about 1/3 of IgA nephropathy, they can carry this IgA entire life, only be found on autopsies. Yes. And then, but 1/3 of patients, they fast progress to end-stage kidney disease in 20 years, 15 to 10 to 20 years, depends on how fast a progressor they are. So I feel like these are the ones that I would test. And in my hands, KM55, and our results is not published. We were a little bit behind for a publication on that. But anyway, so our data showed these cases, either Hep C or cirrhosis-related IgA nephropathy, diabetic secondary IgA nephropathy, they're positive for KM55. And if for infection-associated GN, they are also positive for KM55. But incidental IgA nephropathy, even donor-derived, they're positive. Unfortunately, that's not a KM55. I think the value is not here. It's not helping to distinguish these entities. Yeah.
Yeah, thanks. That's very helpful. And the third question actually has to do with, what do we know about IgG2 deposition? I'm assuming in standard IgA nephropathy that where it's pretty much all galactose deficient IgG1, there is no IgG2. But in the other situations where IgA is deposited, is there often very much IgG2 or not?
Oh, those are great questions, Dr. Crossan. Okay. So to answer that question, unfortunately, our hands are quite tied. Number one, we do not have a good marker to detect galactose deficient IgG. It not even mentioning about galactose deficient IgG1, IgG2, IgG3, or IgG4. Okay, mm-hmm. So for that, our hands are tied unless we have a lab or collaborate with a lab who can develop. If we could have a collaborator, that would be fantastic, because if we read the recent, actually it's not even published, it's in press, that galactose deficient IgG is playing a role in the proliferative GN, in lupus nephritis, etc., etc. So that's a really interesting field to go in. And then coming to the second part of the restriction, or what we can do for now for the IgA nephropathy, because of the thoughts or the multi-hit thinking about this is the immune complex. The immune complex is galactose deficient IgA1 binding with IgG, forming the circulation immune complex, or galactose deficient IgA1 actually with IgA antibody. So those two types of immune complex, right? So even for that detection, I think, okay, the hope is if we use mass spec, we might be able to detect, the differences, whether, it's immune complex deposited in the mesangium, if we have enough antigen. So mass spec, that's a hope. And then coming back to the reality, what we can do. So we can do the routine IgG subclass staining. And then the group at Ohio, they have done that. And then for the IgA nephropathy, they did detect it's a monoclonal IgG. So that supports, or at least one subclass is dominant. So that supports the thoughts that there are immune complex, IgG immune complex. And then there are also studies showing, even by routine IF staining, that IgG negative cases, when there is elute from the mesangium, from the kidney of the IgA nephropathy patients, and then if they do chemical analysis, actually I forgot the analysis, it's more like similar to mass spec, but in a different way. It's a more purely biochemical method. And then they can detect IgG in the mesangium. So those are the studies supporting its immune complex deposition. So IgA nephropathy disease now is more and more being believed as immune complex GN.
Right.
Yeah.
Great. Again, fantastic study. I really appreciated hearing it.
Thank you so much.